least this one is sort of vaguely understandable. It's about commissioning support. My worst one was system management, where most folk actually, in fact, didn't know what system management was and didn't recognize there was a system. So, hey, at least this is an improvement. I'm going to just give some context to the engagement we want to carry out over the next few months around approaches to procurement. I'm going to start by locating it in our strategy. We've published today NHS England's strategy for developing commissioning support services with some key tools, a choice app for CCGs. We've made real progress in terms of partnership working between the CSUs and Akivo, the voluntary sector, scaling up CSUs with NHS IQ, but we want to focus now actually on the procurement stuff. So we now have a strategy for developing commissioning support. We just need to actually make it a reality. So what's it all about? Well, it basically comes down to, I think, a very strong relief which Malcolm, our chairman's just echoed, which is that actually we want great outcomes. And for great outcomes, we need a great commissioning system, and we need actually great commissioners to deliver that. But for commissioners to be great, they need excellent commissioning support that they can afford. So the only goal of our strategy is to ensure that every commissioner, by which I mean CCGs and direct commissioners and ultimately local authorities, can access excellent and affordable commissioning support. And it can be sourced in-house, it can be sourced on a shared basis collaboratively between CCGs, or of course it can be outsourced through procurements with CSUs, with their partners, with the independent sector. The key thing, though, is that commissioning support needs to be able to actually deliver not just the usual transactional stuff, so commissioning cycle, needs assessment, specification, contract negotiation, and management, but actually also commissioning for transformation. So as Malcolm said, key challenge for commissioners over the next 3 or 4 years is that leadership of major service redesign and transformation to deliver much improved outcomes and value, to start to tackle the issues around demand and making the best use of tight funding. So commissioning for transformation to deliver what I guess in old currency we'd call the quick challenges. Commissioning to seriously grip quality. One of the recommendations of the Francis Inquiry that's often underlooked are the 2 or 3 around actually expecting commissioners to seriously systematically grip quality through contracts and drive it up now. And some will be able to do that on their own, and others actually will need significant support, but it's a key issue. And hopefully not coming to you soon, but in some systems, NHS providers, FTs will fail, or there'll be other failures in the system, and there's a whole issue of what do you do actually, in fact, when one or all of your providers are struggling. What's the commissioning response to that? So we need highly excellent, highly competent support for commissioning around transformation, on quality, and also, sadly, addressing failure. We're adopting a market-based approach. I'll make no apologies for that. It's driven by our firm commitment that commissioners will have the right to choose their providers. So they get the right to choose actually how and from whom they source their commissioning support. We also want to actually adopt a market-based approach because we believe that it will help create strong incentives, much stronger incentives than currently, for commissioning support suppliers to be much more responsive to what commissioners want and need. So to develop the sort of innovative service offers that actually help CCGs in the clinical leadership role around transformation, in addressing failure, in gripping quality. And we also think it's a good way of encouraging, enabling market entry and new partnerships. So one of the things I'm delighted about today is the partnership between NHS, CSUs and Akivo, the voluntary sector playing in their expertise. NHS IQ are going to be working with CSUs to gain access to transformational skills, but we're going to need all of that, a much bigger, richer resources, including from the corporate sector, if we're really going to help CCGs drive major change around urgent care, integration, and the one we all forget about, but is pretty key, which is 24/7 services, which for a commissioner I think is a huge challenge. So that's the good reasons for adopting a market-based approach. It's also because because there's already a small emerging commercial market, and we'd be stupid to ignore what that can bring. Procurement law applies to most commissioning support services. There's an expectation of fair and open competition, but there's also a but. We have got a very emergent market, which is quite immature on the provider side, on the CCG side. Commissioning matters, and what we can't afford to do is to actually have chaos. So we're taking a managed approach, deliberately a managed approach to the development of the market. Why procure? Well, hopefully most CCGs in the room are aware of this. You've got a duty to ensure your buying decisions deliver value. The model constitution reiterates that when you're buying goods and services, there's a requirement for proper competition. Through a fair and transparent process, you allow suppliers then to compete against the best. I think that will create a very strong incentive, particularly for CSUs, to ensure they're meeting your needs, and CSUs are driven by their customers. And then lastly, there is a requirement in terms of evolving a market to move from SLAs to legally binding contracts, won through competition. Not because I think actually, in fact, managing through contracts is a good idea, it's a very bad idea, and normally a sign that the relationships are bad, but it is actually about moving towards a more adult and transparent relationship when CCGs know what they're buying, and CSUs and other providers know what they're expected to deliver, for what and to what value. There are some key decisions that CCGs and other buyers need to make, and for anybody thinking in the room about actually wanting to go to procurement this year, there is actually a guide to the basics we produced, which you can get from the NHS England stand or download. The three key decisions are, well, should you buy your services independently, jointly, or with other buyers? My own view would be, depending on what you want, then actually you're more likely to get better value out of providers if you're collaborating. And I think for those CCGs looking for end-to-end services, most of the commissioning cycle, that it may well actually in fact make sense to use your collective leverage. Key issue about actually what you need and how to measure quality, and then in terms of actually how you're buying, well, we've given some guidance around the OJU stuff. Although what I would say is that clearly we need to ensure that any procurement complies with OJU. I think to actually make choice happen in a way that actually meets CCG's needs but doesn't distract them, we need very, very simple procurement processes. So really moving on to that, we've done a fair amount of engagement over the last few months with CCGs, with local authorities, CSUs, social enterprise, independent and voluntary sector, and we've heard a number of things that we need to get right in our approach to procurement, which we're going to develop over the next few months. The first thing was that actually, in fact, there was a preference amongst many, but not all CCGs, for having a single procurement route via a lead supplier, who actually, in fact, acted, if you like, as your gateway in terms of bringing in other resources. Because of that, again, many, but not all CCGs recognise the benefits of actually using some form of framework, and there's a fair degree of support, I think, certainly in the CSU provider community for a lead provider framework approach. But we need to make sure that any approach we take, firstly, doesn't deny CCG choice, and secondly, doesn't actually, in fact, deny innovation and freeze out specialist providers. So there's a whole thing here, really, for lead provider, whoever's actually going to bid to be accredited or lead provider needs to be clear about their partnerships and how they actually network in to get the other resources. We're very concerned that we maintain talent and we don't lose experienced staff, and there's also concerns about actually, if we're not careful, we'll end up spending a lot of money on transaction costs around procurement. And again, CCGs have expressed a varying need for some support as they go through the procurement process, but very variable. So that's sort of what we've heard so far. I'm keen that by the autumn, we've got an agreed approach to procurement, or an agreed set of approaches to procurement, that actually makes it as easy as possible for CCGs to exercise choice and providers to respond to. We've set ourselves the ambitious target between Andrew's, Kenworthy's team and mine of trying to visit virtually every CCG one way or the other between now and late August, just simply because this is so important to CCGs, and to talk more generally about commissioning support. We're very keen to get your thoughts on this. We produced a briefing document and a basic questionnaire which has been published on the website. Really want your views, but recognise it's the sort of thing you need to have a serious think about, then we need to engage with you, so I'd rather do it face-to-face over the next 2 or 3 months. But we do want to be in a position where we can publish our final approach or set of approaches in the autumn, because our expectation would be it's probably 2014 when most CCGs will be wanting to go out to procurement. That's what I'm going to say at this point. I'm going to hand over to my colleague Karen Manners from the NHS Business Services Authority, who's supporting us in trying to work out sensible solutions and approaches to procurement. She'll walk you through the issues, and then we've got a fair amount of time for questions. Karen.
Good afternoon, everyone. Okay, sorry about that. Okay, so clearly a few people don't know who the NHS Business Services Authority are, so there's perhaps a little bit of work to do there on our brand. For those of you who don't, we pay pharmacists, dentists, we have NHS Protect, we look after NHS pensions, and we provide some shared services to a number of customers, including NHS England. So as Bob said, we've been working to assist in mapping out a commissioning support service approach. And so what I hope to do as part of this is make sure that whatever we end up with following market consultation, it is something that is suitable for commissioners and it is simple and easy to operate. Okay, so a little bit about procurement. Most commissioning support services would be classified as Part A, and as a result of that, there is quite a complex procurement process that is required if a CCG or any other commissioner wanted to commission support services above £113,000, not a lot of money. And so there's a couple of options. Either each CCG or commissioner could go out and undertake their own competition and undertake a process called ODU, where the requirement is advertised in Europe and suppliers can bid against that. That can take some time, it's quite complex, and the risk of challenge is fairly high. Typically, it takes 9 to 12 months for that type of arrangement to be set up. Another alternative, which from early engagement it appears is attractive to CCGs and other commissioners, is to access an existing framework agreement. And what would happen would be the framework, the authority setting up the framework would pre-qualify suppliers so that commissioners could then access those suppliers through a locally based competition. Legally, there are various types of framework, and I'm not going to bore you with them. All I wanted to say was there is only one that gives commissioners choice, and that is a multi-supplier framework. What that means is it will give you pre-qualified suppliers, and then a local further competition would be needed by the commissioner. That's much quicker, and it varies, depends how good your procurement support is, but on average for a complex service such as commissioning support services, it would take around 3 months. You would still need some procurement expertise even if you went down the option 2 route, but actually it's a little bit easier. The risk of challenge, legal challenge that is significantly lower. And the other thing that I think we can help with is we can set up tools and templates, we can create standard service specifications and documentation to make the further competition that commissioners have to do that much easier. That isn't to say that commissioners won't be able to amend that, because obviously the whole point of this, right, is it's got to be suitable for the local needs in your local area. But you would have, if you like, a toolkit of documents that you could use to undertake the further competition. So Bob's talked earlier about the findings through the early market engagement, and in terms of the procurement approach, the suggestion that we're taking into the market engagement is that, first of all, we can assist with helping you find the right procurement mentors and advisors. And what we could do is provide you with a list of options about where you can access those services. There are existing frameworks that exist. So Consultancy One, for example, one of the government procurement service offerings, would allow you to access advisors through that route. We can also give you access to preferred lists of suppliers as well for smaller value activities. But the main event, if you like, is how we propose to structure the commissioning support services infrastructure so that you can commission support services effectively. And as Bob mentions, that's through a lead provider framework, which will definitely reduce procurement timescales and transaction costs, because instead of every commissioner having to go out and do their own European tender taking 9 to 12 months, it will be done once at the start. Other issues that we want to discuss during market engagement is whether there is some sense in phasing the competitions that will take place at commissioner level so that everyone is not inundating the supply market at the same point in time. So we want to see if that's got any traction or interest to the commissioners. Another aspect of the framework which we're keen to explore is, in my view, the absolute worst case scenario is we give you a framework that's fixed for 4 years with the same suppliers on, and you can't change suppliers or have any ability to respond to local needs within your patch. And so what we want to do with the lead provider framework is make sure that we can dynamically introduce new subcontractors over the life of the framework that will be able to respond to commissioners' needs on the ground. And we can build that into the framework. Okay, so what is a lead provider? It doesn't mean that a lead provider would have to provide every service themselves. They can do that either in-house or through subcontracting. We're keen to make sure that we access all parts of the market, and that does include third sector, voluntary sector, the SMEs, to make sure that we get the right support at the local level. We also want to make sure that we build a solution which allows CCGs and other commissioners the ability to vary and change their service level arrangements over the duration of the contract. I mean, it's not quite that simple as you might expect. There are a few legal issues there, but we're going to make it absolutely as flexible as is possible. So following the early engagement, we've co-developed some service categories, and over the course of the next few months we want to talk to commissioners and others about whether we've got the categories and whether there's anything missing. So, commissioning support services, it's obviously a diverse bag of issues. It's everything. The middle block is all about supporting the commissioning cycle and providing end-to-end services. There's a lot of other stuff that you need around things like financial planning, accounting, reporting, payroll, IT, etc. And that would also be part of the package, as well as some clinical support services that tend to be linked to a specific clinical pathway. So we're not saying, by the way, that as a commissioner you, first of all, even have to use this framework. You only use it if you like it. And if you like it, you can either use all of it if, as a CCG, you want to concentrate purely on the clinical side of business and pass over all of the support services to a provider. You could use this model for everything, or else you can pick and mix. It really would be your choice. At this point in time, from the consultation that we've undertaken, we believe that the right thing is to exclude major reconfiguration from this framework. And that's partly because there are other offerings out there which allow commissioners to, there are current frameworks that can be used for this service. But again, if we've got this wrong, we're happy to talk about it. That's one of the things we want to talk about as part of consultation, to see whether there is indeed a case for an additional new framework for major reconfiguration support. So, both Bob and I have talked about a few key themes. So just to bring them all together in summary fashion, we want to make sure that all commissioners have access to a decent level of procurement advisor and mentor support. Earlier, people have talked about the fact that there can be a lack of there is definitely a lot of technical expertise out there, but it's fragmented. And we want to give you the information so that you can access the right procurement advisors and mentors to help lead you through the process. We've talked about the fact that we would like to set up a lead provider framework so that commissioners can access pre-qualified suppliers who've demonstrated that they're capable of delivering commissioning support services, whether themselves or through a subcontractor type arrangement. The other thing that we do, that I'd like to point out on that, is we want to just make sure that we can keep the framework current by constantly refreshing and bringing in the local skills within the area through subcontractor routes. We talked about collaboration and the fact that we don't just necessarily want one provider to provide all of the services. We want the best supplier who can provide excellent commissioning, as Bob talked about earlier, and represent a decent value. And so the lead provider would access other suppliers that operate within the service and can give specialist help. We think there's value in exploring whether commissioners would like to work together to undertake joint procurements rather than 220 odd CCGs going out at roughly the same time. If you have similar aligned interests with another CCG, it may be useful to amalgamate your requirement. You might get a better deal. You might get more interest in your tender. You might get a totally different number of suppliers that respond to your bid. So we'd like to talk to you about whether buyers clubbing together to, on a joint procurement is a sensible solution, and also whether there's any benefit in trying to arrange some sort of phasing of procurements to avoid poor market responses. So I've been in procurement for 25 years, and sometimes, well, all suppliers obviously go for the best tenders that look the most attractive, and really what we wouldn't want is for that to happen. And we want to make sure that all tenders get a good response, and phasing might help with that. And we also want to talk to you as part of the engagement process about whether there is any benefit in our producing standard specifications and other tender documents to make things that much easier for commissioners. So, as Bob mentioned earlier, we're looking for your feedback on the proposals that we've both just walked through. We've talked about the 6 key elements. We want to know if we've got it right, if there are some challenges, risks, other options, things we haven't thought about. This truly is market engagement, and we're here to listen. We also want to know whether you think there's any benefit in undertaking a framework for major service reconfiguration. So that's just a quick whistle-stop tour of where we're up to in our procurement thinking at this point in time, but I'm sure it will evolve as we work with commissioners and suppliers of all shapes and sizes over the next few months. So the briefing document, if all goes according to plan, is now available on NHS England's website as of today. We really do value your input and responses, and very happy to take questions now. Thank you.
Thank you, Karen. Is it possible to go back to the previous slide? Because I think it'll be quite helpful to have that up in front of us if we could. Can you do that from the back, or does Karen need to do it from the front? You need to do it from the front. I'm going to suggest we've got about 20 minutes for questions. I'm going to suggest that we start off with just any questions of clarification that you'd like to make. We then start to explore some of the things under 3 that Karen has put up there. And perhaps if we have time, we'll just come back to a brief discussion about number 4. Would that suit Bob and Karen? Okay, great. Questions for clarification. There's a question here. If we can have the mic, please. Thank you. Great. Just say who you are, where you're from, and put your question.
Hello. Aidan Walsh from Deloitte. It's really is a question for clarification around the lead provider framework. Are you envisaging that would have CSU-type organisations as well as private sector organisations on that framework? I'm just trying to get a handle on whether this is geared more towards CSUs competing or private sector competing.
It's actually quite difficult to hear from up here, so did I get that right? Are you asking the question about whether CSUs as well as other providers would be on the framework?
Yes, exactly.
Okay, do you want me to take that? Yeah. Okay, so this will be advertised in accordance with standard public procurement process under public contracting regulations, and anyone who wants to submit a proposal will be able to. So yes, absolutely. I think it's open to CSUs and any other provider who thinks they could operate in this space.
Yeah, so to be crystal clear, I mean, this is about you, regardless of actually ownership, whoever actually bids will need to demonstrate that one way or the other, they can actually deliver the capacity and the competencies across that whole range of boxes, commissioning cycle and back office.
Other questions? Anybody else? Stick your hand up. One more question over here, and then we'll perhaps get on to talk about item number 3, just at the side aisle there.
Thank you. It's Paul Edwards from NHS World CCG. The question I had was, given a lead provider framework, does that mean you'd have to buy the whole package of things from a single lead provider, or could I say get finance from one CSU and HR from another? I'm just not clear how that would work.
Yeah, did everybody get that? Hopefully the slides were clear. I obviously probably wasn't. I think the intention is that any commissioner could access either the whole suite of requirements, or if they only wanted a specific element, say end-to-end commissioning support or whatever, then they could commission for a subset as well as the complete package.
I mean, it's worth saying that we're working on a basis of some assumptions based on what we've heard from a fairly small group of CCGs, and mainly those actually who are interested in the issue, but actually what they like. There was a fair amount of interest in being able to procure simply and efficiently end-to-end services. So that's most of the commissioning cycle. We need to test that hypothesis out. We also need to make sure there are easy procurement routes for folk who maybe want to provide much of the commissioning cycle in-house but want some serious support around transformation. So we want to actually explore a range of approaches. Doesn't preclude a CCG going off and running their own procurement, but I would hope that at least they'd use the specs and the standard contract terms, because it really doesn't make much sense for every CCG to reinvent the wheel. So we want to make this as flexible as possible, but the problem I have is I've heard from a number of folk what they might want, views differ, so we want to spend the next couple of months actually going out and asking large groups, numbers of CCGs, what exactly do you want to meet your needs? and we'll come up with something that's as flexible as possible.
Thank you. Let's go on to make a few points about this as well as questions. There's 2 questions here. Can the mic come down to the...
Thank you. Robin Stern, Medical Mosaic. Delighted to hear about the flexibility. Is there similar flexibility on the supplier side so that suppliers of niche services, such as service redesign and transformation, but not with the ability to provide the full range of commissioning support, how will they be able to register their presence in this market for CCGs to be able to purchase from?
Yeah, I mean, the answer is yes, we need to do that because I don't want to freeze folk out. There are various routes into the market. One is clearly entering into a partnership as part of a network with a lead provider, whether they're a CSU or a commercial lead provider. Secondly, because I think there will be some CCGs who actually want to access the transformational stuff or niche analysis, but not the whole end-to-end. Having an ability for CCGs to find out who's around, which is what we're trying to do through the Choice app. So I would say, if there are any providers in the room who haven't yet been able to get onto the Choice app, you should go to the NHS England stand and make sure you register, because I want a situation where every CCG finds it as easy as possible to know who's around.
Okay, other questions, comments? There's one here, there's one at the front and one at the back. So we'll go to this gentleman first.
John Wicks, Herefordshire CCG. We're kind of lumbered with geographical brands for CSUs, which, following an open market competition, may not hold a lot of relevance. Say they're, you know, I'm currently a customer of the Staffordshire and Lancashire CSU, which is clunky enough a title when you actually have patients who live in Herefordshire and find it difficult to link with that. If that client base hypothetically were to significantly change, you know, what are we going to call these things in the future?
Okay, I mean, I think whatever makes sense, frankly. I mean, CSUs are evolving rapidly. They will always, I think, have some geographical focus, but I think some will actually specialise in other areas. I think the geographical link, really important from CCGs in terms of having local responsiveness. So I'm not saying that's not important, but I think we need to, during the hosting period, try and get some shift on what they can be called, because that geographical link doesn't make a lot of sense. But I'm not saying that CSUs don't have to be very close to their local customers. But I agree with you, and that branding issue is something I think we've got to come back to later in the year.
Thank you. Question here.
Ben Farrelly, NHS England, London. You spoke about joint procurements. Are you looking to build a database on a national basis so we can, for commissioning intentions, so people could link into that, say what's happening elsewhere and where could we? Otherwise, it's going to be disjointed about how we're going to know.
I mean, the answer is yes. I mean, it's part of building the informed, helping inform choice. So I want to actually make sure that CCGs know who's around. I want to make sure we share best practice in terms of commissioning support and also what's going on the commissioning support bit. So I think I'm not sure quite how we do it, which is why we want to ask over the next couple of months, but having some way that actually CCGs and other commissioners can see who's doing what and then actually can decide whether they want to play in or not, or at least use the specifications so they're not reinventing the wheel, I think would be a really good idea. Don't know how we do it, but I think it's just one of those things that sounds really good common sense.
Fine, a question at the back.
Hi, thanks. My name's Amanda Hoey.
Can you hold the mic very close because it's quite difficult to hear at the front?
My name's Amanda Hoey. I'm from the BMJ. As I understand it, PCTs put about 25% of their commissioning support business through the previous framework agreement, known as FEST. And I just wondered, it's early days, I realised, but whether there's sort of any anticipated percentage that you'd like to see the CCGs put through this framework, or indeed what you might hope they would put through.
Okay, so from a procurement perspective, I think one of the fundamental principles of a framework is people access it if they think it's right for them. And so commissioners, if they like the look of it, if they like the look of what's been set up and they think it's going to save them time, then they will be able to use that. So framework take-up is often quite difficult to predict in advance, something that I've learnt over the years. I don't know, as far as I know, there's no target for the take-up. I think it's just we want to put the infrastructure in place to make things as streamlined as possible for commissioners.
Yeah, I mean, there's no target. What I want to do is to put in a range of approaches that CCGs can choose which ones they're most comfortable with, which ones most meet their needs, which is either using a framework, using bits of a framework, or they can go off and do their own procurements, but making sure they're supported in that.
Got one more question at the front row here, and then I just want to ask a question, just get a feel for where people are at currently and what their plans are.
Brian Westbury, I'm a dentist. CCGs are not the only commissioners, you've said other buyers, and one of the other big ones is NHS England directly commissioning. Will they be going through all these processes?
NHS, we've got to work out actually, in fact, the approach for NHS England procuring services. It depends on actually who they're going to procure from and what. So there's a major review going on in NHS England of what its approach to procurement should be. We're going to design a procurement framework for lead provider and so on that hopefully will actually avoid a lot of duplication around specifications and so on. But it's then for NHS England direct commissioners to decide what route they want to actually follow. But I really, the one thing I want to get out of this is that we end up with a set of simple processes that actually capture what we're trying to do about decent commissioning support and actually don't end up with 211 CCGs all doing things independently and differently, and on top of that, bits of NHS England do it differently and so on. So what we're trying to do is to actually get an approach that's coordinated and as aligned as possible, simply because that will save a lot of money and time.
And just a procurement point from me, which is, Andrew Kenworthy was talking earlier about whatever happens, folks have to follow the law. And basically, if NHS England is procuring services, the Part A services, they have to follow the law, no different to any other commissioner in that sense.
Okay, I just want to get a feel for where people are. I appreciate there's a big spread of people here, but if it applies to you, have you got commissioned from your commissioning support unit end-to-end commissioning support? Can I just see a show of hands? A few. How many of you have gone the other end of the spectrum and just commissioned a minimum of commissioning support from the... And how many of you would regard yourselves as in between? And the rest of you are at the wrong conference, I presume. Okay. So there's quite a spread there. Now, another question, how many of you feel that you're going to need to make significant change over the next couple of years in your commissioning support arrangements? So a reasonable amount of satisfaction there at the moment. I think there's a lot of tentativeness about this. I think people are still quite uncertain about it. But clearly there's a spread. Will that spread in the approach affect the procurement process hugely?
Yes, in the sense that actually I've not got a target for any approach to procurement. What I want to do is to make sure that actually whatever range of approaches we come up with enable CCGs to do whatever they want to around getting the best commissioning support. My own view is that actually for those people who want to commission much of their commissioning cycle stuff and so on, and transformation, that end-to-end or some variation of that lead provider is a sensible approach. I think where CCGs have got common needs, then encouraging joint procurement collaboration is a sensible approach. But equally, I recognise that actually some CCGs are in a very different position, and if you're doing it mainly in-house, there may be particular services that you want around transformation or back office or whatever, and we need to enable that. But the key thing we need to ensure is that every commissioner has access to excellent commissioning support that they can afford, and a key challenge for that, whether you're actually a buyer or a seller, is making sure that we get the benefits of scale. So one way or the other, a lot of the back office, the commissioning cycle work and so on, we need to get done at a big enough scale, and there are all sorts of ways you can do that, like CSUs partnering with each other, CCGs entering into deals with CCGs around that. But it would be criminal if we didn't, in a couple of years' time, manage to extract significant efficiencies from actually doing those things at scale that need to be done at scale. But there's no prescription in terms of how you get there.
Great. Question here, please.
Roger Hymas, Health+Care Commissioning Services. I just wonder if I could ask you for one more sample question and ask how many suppliers are in the room.
Sorry, go on.
How many suppliers?
How many suppliers are here, did you say?
Oh.
How many suppliers, CSUs, are here? All right, you greatly outnumber the commissioners by the look of it. Okay, and how many of you would say that the majority of your arrangements currently are end-to-end commissioning? How many would you say are mostly minimal? And how many of you are in the middle? And some of you clearly don't know that you're a support unit. Okay, so there's still quite a large spread here, and I think still there's a lot of people feeling their way, and I think a session like this is being quite helpful. I think we've got chance for one comment or question about point number 4. If there's anybody, there's a question. One at the back here.
Sorry, I'm not too sure it's about point number 4, but it was a question I think needs to be asked. I'm Martin Flanagan from GEM. Are you sure that the commissioning market is ready for this and the supplier market is ready for this? Because we're still in a very immature market, and this is a dramatic change, which, if the results are wrong, could be quite a substantial effect on patient health care.
Yeah, no, I mean, it's a really good question to end on. So am I sure that actually commissioners and providers are in the right state? No, but I'm not going to I'm going to avoid insulting some folk. Some CCGs and some CSUs and providers are not far away from that. But my view would be that actually we need to do a lot of work to support CCGs and NHS England as direct commissioners to gear up to be informed customers. Equally, in terms of the provider market, there's a long way to go. We need to be in a position where every CSU understands its costs, understands actually its customers' needs in some detail, understands its competencies in any gap, and has actually got a good business model to actually then buy in through collaboration, whatever those skills. So that needs to be the focus for the next year. My naive assumption is that not many CCGs will want to go out this year, and therefore it's a 14-15 issue. We cannot afford to waste any time, though, in the parallel development, and it needs to be parallel, of commissioners and providers. And that's one of the key questions I want to ask as we engage people over the next 2 months. If we go down this line of these different procurement arrangements and so on, what does that mean in terms of the development support for commissioners, and what does it mean for CSUs and other providers in terms of their business model and what they need to do? There's no point in going out to procurement if it achieves nothing. That's a waste of money. We do need, for the reasons said, to move into procurement. When we do it and how are two really important questions, and that's why Andrew's team and mine want to be out and about with Karen and her team over the next 2 or 3 months to really explore that and do it face to face. So our offer is we are happy to go out and see 1, 20, any grouping of CCGs commissioners that make sense. We're also looking to engage with a whole plethora of providers over the next couple of months to try and get this as right as possible, because these are very much interim proposals which we may or may not have got right. If we can get them right, I think it would be great. But if we get it wrong, it could be hugely damaging and very expensive, and end up actually, frankly, with the CSS market saying as it is, which would not be in patients' interests, because we do need great commissioning support to get great commissioners. So this is a serious attempt to actually go out, listen, and try and get it right. What I'd like to do is, as we do that listening process, publish the outcomes. So not naming folk, but this is what we've got in so far, therefore we might need to consider our proposals, making it really iterative. But if we don't get the engagement, particularly from commissioners, the chance of getting it right, I think, is quite low. So we really do need your engagement. I know it's not the most sexiest issue in the world, but it really is important for the future of CCGs in terms of being great commissioners.
Great, I think that's a good point for us to break this session. It's been good to have some debate, and clearly everyone is going to have an opportunity to ensure that their voice is heard. Just a reminder to fill in your feedback forms, and please take all your papers and any rubbish with you so the hall is ready for the next time. But in the meantime, let's say thank you to Bob and to Karen for an excellent session.